work at 3 hospitals. I work at the Essex Cardiothoracic Centre, and that's a specialist heart hospital in Essex. And then I also work in Springfield Hospital in Chelmsford and also Broomfield Hospital in Chelmsford. But most of the cardiac procedures I do are at the Essex Cardiothoracic Centre. I was initially an undergraduate in Cambridge, and then I went to the Oxford University Medical School for my clinical training. Then I did some house jobs in Oxford and Nottingham, and then my specialist cardiology training, that was initially at the Hammersmith Hospital in London, and then I went to Papworth Hospital in Cambridge. Whilst I was in Cambridge, I also did a PhD in cardiovascular molecular biology, which was done during that time. So that was my training in those hospitals. Well, I deal with a range of cardiological conditions. We see patients who've had heart attacks, we see patients who have arrhythmias, particularly atrial fibrillation, people who have heart failure, people who have valve disease, and increasingly as well there are people who come to see cardiologists before they've developed heart conditions with the idea of seeing if they can prevent the development of serious heart problems later in life. And these may be people who have had family members who things have happened to at a relatively young age, or people just generally concerned about their cardiac health. I do a range of procedures. Many of the procedures that we do are diagnostic procedures, so these are coronary angiographic studies, and the purpose of these studies is to see if patients have narrowings in the arteries to the heart, and then to assess the valves or perhaps the ventricular function in detail. So part of the procedures are diagnostic procedures to find out what's wrong with the patient. In addition to that, I perform some what we call interventional procedures. So these are types of operations performed through catheters. The most common one I do is coronary angioplasty and stent procedures. So these are for patients who have narrowings or furring up in the arteries to the heart. And this can be a planned procedure for some patients who have chest pain, and it can also be done as an emergency procedure for patients presenting with heart attacks. And we run a large service in Essex for our heart attack centre. So in addition to coronary work, I also do some other what we call structural heart procedures. So there are some patients who have holes in the heart called PFOs, and these are sometimes the cause of strokes in young patients. And there's a procedure where these holes can be closed through a catheter, through an incision that's only 2 millimeters in diameter. And also there's another procedure called left atrial appendage occlusion, and this is for patients who are at risk of stroke related to atrial fibrillation, who may have a problem taking warfarin, and it's a one-off procedure, which means they don't need to take warfarin for the rest of their life. That's a very good question, and it's a very common question that patients ask us. They want to know what's the best option for them. It's fair to say that patients often prefer the least invasive option, and in many cases that's the stenting procedure rather than the open operation. What's important is that there's no right and wrong answer that applies to everybody. It depends on what the arteries look like. So it's impossible to give an answer to a patient without doing the angiogram and seeing what the coronary arteries look like. When we advise patients, and it's often a discussion about the pros and cons of different procedures, what we usually say is we want them to recover quickly, but probably more important than that is we want the best long-term treatment for them, thinking ahead for years in the future. And in many cases a stent is the best option, but there are certainly many cases as well where an operation is the best option. So it's a decision that can only really be based on knowing the exact anatomy that the patient's coronary arteries look like, and then it's a discussion with the patient over the pros and cons of both options. That's another important question that many patients ask. And what we're aiming to do with interventional procedures is to deal with furring up in the arteries, but what we want to do is to have a definitive procedure and not come back to do further procedures in the future. Many years ago, what we used to do was we'd do stenting procedures, or patients would have bypass operations, and then they'd come back a few years later with further problems. What we know now is that if you get the risk factors under very good control and this involves drugs to thin the blood, statins to keep the cholesterol low, blood pressure lowering agents. If we get those right, then in many patients they never need another procedure to be done in the future. So it's important that people are on preventative medication to try and prevent problems in the long term. There's a lot in the press about statins. Undoubtedly some people do get side effects from statins, but it's fair to say that the vast majority of patients can be maintained on statins without any side effects, and it certainly makes it less likely that they'll need further procedures to be done in the long term. Well, atrial fibrillation is a very common arrhythmia, and it's when the heart goes into an irregular rhythm rather than a nice regular rhythm. And sometimes people feel breathless and they might notice palpitations, but sometimes people can have no symptoms at all with this. Now there's a little pocket of one of the top chambers of the heart called the left atrium, and this is where little blood clots can form in patients who get atrial fibrillation. And the main concern about these blood clots is they can fly off and fly into the brain and cause strokes. Now strokes are something that can be absolutely devastating for a patient, and of all the medical conditions we want to prevent, stroke is really one of the most important. So atrial fibrillation is an arrhythmia that we know in some patients can be associated with blood clots that can fly off and cause strokes. So it's important that we recognise atrial fibrillation, and it's important that we do what we can to try and prevent strokes happening. Many patients have got friends and relatives who take warfarin, and they're aware that you have to have blood tests, and they're aware that sometimes the amount of warfarin you need can vary, and people find it sometimes a bit of a nuisance in terms of therapy, but it's still worthwhile for many people, and it's still the first line for many patients with the aim of preventing strokes. There are some newer treatments available, and there's two I'd like to mention now. One of them is something called the new oral anticoagulation drugs, and these are drugs that act like warfarin, but you don't need any blood tests to monitor it, so it's a fixed dose that the patient gets, and there are some advantages with these. But there are also some patients who, for other reasons, they can't take drugs to thin the blood. So an example might be if you've had a brain hemorrhage, or if you've got recurrent bleeding in the gut, you can't be maintained on drugs that thin the blood, because all drugs that thin the blood make it more likely that you'll have bleeding episodes. And for those patients there's a newer treatment called left atrial appendage occlusion. So I've mentioned before that in atrial fibrillation there's a little pocket of one of the top chambers of the heart, and that's where the blood clot forms. But there's a procedure I perform called left atrial appendage occlusion, and this is where a little plug can be put into that pocket, and it means the patient doesn't need to be anticoagulated. So there's an alternative to many decades of anticoagulation for suitable patients. It's not a treatment that's available or suitable for everybody, and it needs a very careful discussion, but for most people with atrial fibrillation we would recommend that they're on warfarin or one of the newer drugs. But in patients who can't be maintained on those drugs, who are at risk of a stroke, there is this procedure, a one-off procedure, and it's something that's likely to develop and be more commonly performed over the next few years. Yes, they can, and this is another area of interest I have. And historically, many holes in the heart needed an open operation to close them. And in fact, this is still necessary for some types of defects in the heart. But there are some defects in the heart. An example is a PFO, and this is something that we think can contribute to young patients who get strokes. So most strokes are in elderly patients. It's unusual for young people to get strokes, and when this does happen we look into it very, very carefully, and what we sometimes find is they have these communications in the heart called PFOs, and this is something that the defect can be closed in a very simple procedure, a catheter-based procedure, and it's generally a pretty successful option. So it's something that for closing a PFO, it's very rare that you'd need an open operation these days. And once again, it's a treatment aimed at preventing stroke, but this is in an unusual cohort of young patients who get strokes. I think in many areas of medicine now, it's probably best that doctors work together as teams and groups. So rather than individuals recommending treatments and making decisions by themselves, it's often a good idea to have groups of doctors who discuss cases together. It means you can share experience, and it means that you can get expertise from other areas. When we see patients who need stenting procedures, or who might need atrial appendage occluders or PFO occluders to close holes in the heart, it's often a good idea for groups of doctors to discuss the pros and cons of different treatments. So even though the patient may only see the cardiologist, what they should remember is the cardiologist may discuss the case with his other colleagues and with cardiac surgeons, and the aim is that the advice given to the patient is the best possible advice for the long term. I think there's two general themes to the new treatments that are going to be available increasingly in the future. One of them is early recognition and prevention of heart problems. So instead of waiting till people develop serious heart problems and needing things to be done, then I think we'll probably get better at identifying the earlier stages of diseases and being able to do something about that. And there are newer ways of detecting very early changes in the arteries to the heart, for example using CT scanning technology, and these are things that we increasingly use now. There are ways of assessing whether the patient's heart is under strain when they exercise, and there are ways of assessing the function and the valves of the heart. So we're very keen on identifying problems with the heart very early on, and in many cases you can then prevent problems. In the patients who do present with heart problems that need something to be done, the aim now is generally to try and see if it's possible to do the procedure in as least invasive way as possible. So for example, in many elderly patients who may not be suitable for general anaesthesia, to see if they can be done under local anaesthetics, and to see if procedures can be done through smaller and smaller incisions and wounds if we can possibly do this. And once again, this is something where as groups of doctors we often collaborate on this. So cardiologists may work with surgeons who have particular interest in doing procedures through what we call keyhole access procedures, and it's very important to be able to discuss these with the patient to recognise the pros and cons. But the two things in general, one of them is recognising things early and being able to deal with things in as least invasive way as possible, and this is something that Keyhole Clinic is pioneering.